Hello, welcome to Arthritis at Home. Today on a special episode, we're joined by Westby and Cheryl Koehn. Marie is a physical therapist at Mary Pack Arthritis Program and clinical associate professor at the Department of Physical Therapy at the University of British Columbia. Marie is also an associate member of the Center for Hip Health and Mobility. Cheryl, as many of you know, is the president and founder of Arthritis Consumer Experts. Welcome to you both. How are both of you doing today?
Great, thanks, Kelly.
Pretty good. I'm all the better for being here with Dr. Westby and yourself. Thanks for the invitation.
The idea for today's episode actually started with one more special guest who's with us today, and that's Cheryl's new knee, which just passed its 1-year milestone. I'm not sure if it's a birthday or a milestone. And we were planning to talk to you, Cheryl, about your 12-month experience, but also to get some expert perspective from Dr. Westby on the current state of total joint replacement, or TJR, rehab in Canada. So that's what we're hoping to cover off today. So I guess the first question for you, Cheryl, is what was the rehab, the formal therapy experience like for you?
I guess rehab, in my mind, starts the minute you kind of are aware and wake up in your room, frankly, at the hospital on ward. Because what you do from the very beginning post-surgery and getting locked into the rehab mentality, as I've learned and been told, is super important for long-term success. So the early days, Kelly, were I'm not going to sugarcoat it. It's hard. The first couple of days, it's a bit surreal. You're trying to get your head around the fact that part of you is not there anymore. You have some foreign thing in your body, and it's just, there's not very many words to describe that feeling. You're trying to sort of get over the meds that they put into you during surgery. So you basically feel a little sickly, but you've got this new thing in you that you're trying to test out. And over time, you grow comfortable with that. And I'd say the first 6 weeks are the toughest. The first 2, basically, you're on your own at home healing, and Dr. Westby kept reminding me of that. During my early journey. Well, Cheryl, you're not going to get up and run a marathon in the first week. You're not even going to really want to walk around the block in the first week. So I'm a type A, and I'm a person who had an athletic career before starting my volunteer and paid life in arthritis as an educator. And so I had to get my head around that. But overall, once you get over that 6-week hump, it really is about persistence, perseverance, patience, all those P words, pride, take pride in every little step you take or every successful exercise that you do. And when you leave hospital, I think probably, and Dr. Westby can correct me here if I'm misspeaking, but across Canada, in each province, there is sort of a formal educational program that might be made available, though it might vary by region. Here in Vancouver, where I live and was operated in, I really relied so heavily on the great patient guide that Oasis, the program that manages some of the educational programs for people who undergo joint replacements, as well as the Mary Pack Arthritis Center. Because I have rheumatoid arthritis, I went into that program for 6 weeks, and the first few days were just brutal. But the therapist there kept reminding me, Cheryl, it will get easier. It will get easier. You will start to feel like you can make that knee do what your other knee used to be able to do. So I would say, Kelly, those first 6 weeks, a few days in hospital are brutal. First 6 weeks are tough, but doable. But once you crest over that 6-week mark, you really start to feel different. And by month 4, I was back in the indoor cycling studio very quietly, patiently, turning the pedals on the bike. And it turns out riding is really, really good for people who have knee issues. And my whole focus was rebuilding my quadricep. My knee was really bad for several decades. I went along with a bum knee for a long time, so I had quite atrophied quadriceps. So I really focused on that. And after year one, I can say this summer, I've ridden my bike from Vancouver to Squamish and back. It's 134 kilometers, believe it or not. I've climbed about 1,800 meters during that ride. I've ridden a couple of 100-kilometer rides. I'm walking my dog, which was really my primary objective in rehab, but it's just been terrific.
So that, just to go back then, that 6-week mark.
Yeah.
After that 6 week, is that when you are taking charge of your own rehab and self-care?
Do you know, I must say that I felt, and I think it's probably important that a lot of people going through this feel this way, I think our healthcare professionals, those that I came into contact with, instilled in me that I'm actually in charge from day one, that I have to do things in the hospital bed. Like you literally start rehabbing in your hospital bed. And there are a set of very simple exercises that they give you, and 3 times a day, like clockwork, you do them. Some of them are sort of very isometric type of exercises, like trying to flatten your knee on the back of the bed. Believe it or not, that's rehab. And getting the knee straight as early as you can and bent as much as you can in that first 6 weeks. That was my raison d'etre, Kelly. Like, it's all I live for. Marie could tell you, but I'm only at 100%. I'm only at 100 degrees. I should be at so that's really, from day one, you are in charge, really, and you're being guided by your therapist.
So Dr. Westby, just to put a expert perspective on this, I guess a couple of questions. First of all, as it relates to Cheryl's experience and going through a tough 6 weeks, but within a couple of months after that, to be able to resume the kind of activities that she was describing, is that typical for a patient who's gone through knee TJR?
Cheryl's on a little higher end in terms of sort of what we might call like a recovery curve. So certainly the first, I totally agree with her from the years of experience I've had here watching patients go through a hip or knee replacement, especially with knees. The first 6 to 8 weeks, I would say, 2 weeks at home, as Cheryl noted, before you might start rehab, and then another 6 weeks of rehab. So you're about 2 months post-surgery. That's a good result. And that's when patients start to say they've got control of the pain, or the pain is no longer controlling them, and they have some more ability to start getting out. And some people are going back to work by then. Some people are driving their car by then. But for others, and with an older population, and Cheryl is on the younger side of people who
have thank you
of hip and knee replacements, we're looking typically more at probably 3 months. So I'd probably add another month on there. Unfortunately, rehab often doesn't continue right through that period of time, but people, as Cheryl said, right from the beginning are instructed to do their own home exercises and that. But patients will tell us it's usually typically at least 3 months. And some do better much faster, like Cheryl, with a lot of hard work, and others take a bit longer. They're a bit older. They have other comorbidities or health conditions that they're dealing with. And they're starting at a lower state of fitness, and they're trying to make up for that as well as recover from a knee replacement.
So age a big determinant, and then you talked about comorbidities. Would weight and obesity be a major one in that area?
We know that people, especially who have knee replacements, data from across Canada shows that more than 50% of people are obese who have a knee replacement, not just overweight. They still do really well with knee replacements. They get great results, but yes, they have additional challenges. They have some additional complications that can occur in hospital. And by probably the major comorbidities, and as Cheryl can attest to with having rheumatoid arthritis, it's not just your knee joint. That's solving one problem, probably the biggest problem, but it might also be your other knee and your other hip and maybe your elbows and your shoulders. So Dealing with all those other comorbidities or other orthopedic problems can also delay the progress, because now it's not your knee that's holding you back, it's those other joints that are actually more problematic.
So for our viewers who are having complications with hip or expecting to go into surgery for their hip, that the process and timeline that we've heard you talk about, you and Cheryl talk about for the knee, is roughly the same or parallel for the hip.
Hip replacement surgery tends to be a little faster.
Okay.
It's a very different surgery. It's a different type of prosthetic or metal and plastic components. In many ways, a lot of people who have had both hip and knee say it's not quite as painful. The recovery is a little bit faster for hip replacements than knee replacements. But again, it really it's based on their preconditioning, their previous fitness level, and a lot of other things going on in their lives.
So Cheryl, once the swelling subsided and ended, I guess the next thing that I've heard other people talk about is just the scarring and how severe the scarring could be or can be. What sort of scar management steps did you take?
Well, it's interesting. Scar management, or wound management, I should say, before is important, even before you get your sutures taken out. As I learned so well from my physiotherapist, like, that's why you really need to focus on bend, but as well straightening, even in the earliest phases. And even today, 1 year later, I can feel little electrical impulses coming up the front of my shin sometimes if I'm bending my knee a bit past maybe where I feel quite comfortable, which is related to the scar, right? It just doesn't have that elasticity over the skin. But I'd say on the whole, from once the wound is healed, I was recommended to put vitamin E on it. There are some over-the-counter products. I purchased a few of those at my local drugstore that's for scar management, and I put that on morning and night. You have to make sure the wound is completely closed. But I think more so than what you put on it, it's what you do with your knee. And Dr. Westby can probably offer some insights into that, but it really is trying to take the knee and really release, because there's scarring inside the knee as well as on the surface of the knee. And it's about trying to keep that bend. And even today, Kelly, 1 year later, every single day I put my foot on the stairs, my operated on knee, the foot on the stair in the back, and I work on quadricep stretching, which helps with my knee bend, because it's not, you don't just finish rehab and then call it a day. Rehab for me, this is my approach. Rehab for me and scar management for me is every day for the rest of my life. That's how I view it. Because the minute I feel I kind of say, oh, I'm done, I don't have to do that anymore, I feel my leg not as strong. I feel I lose some mobility or range of motion. And even, for example, last night, and the swelling even a year later isn't fully gone, Kelly. Like, you don't look at my right knee versus my left and say, oh, those are the same. I still have a pad of swelling at the front of my knee and a little on the side, not much. So I still ice every night. I put a bag of ice on my knee for 10 minutes. And boy, the next morning when I wake up, I know the difference. It's quite something. So I think of the scar management in several ways: the inside, outside, and just and understanding that scar does play a role in my range of motion.
So you talked about ice. Are there any other sort of post exercise treatments that you do or follow as part of your ongoing rehab?
I've always been a stretcher, like stretching equals strength.
Yeah.
And I think probably most people, or a lot of people who haven't been into athletics for a period of their life or throughout their life, maybe don't understand that. So one thing that I do religiously morning and night is stretch. And I have a roller, and I roll my quadriceps, my hamstrings, my glutes, my calves. So, and on both sides. So it's not just the operated on side, because balance is really important. You don't want to ignore, the non-operated side, because it, as Dr. Westby said, you're carrying, you would early on, you tend to favor things. So you have to try not to do that. So I would say stretching, Kelly, and strengthening. I do, because of COVID, I call them my kitchen workouts. So 3 times a week, I'm doing a lower body, and I'm doing it just with my own body weight. But I must say, I think I've never been stronger now than in the last sort of decade because of my kitchen workouts.
Dr. Westby, I'm just wondering right now, in terms of the last 5 or 6 months and the pandemic, what sort of disruption has that caused people like Cheryl, Cheryl fortunately was sort of halfway through her year of rehab when the pandemic hit. I'm thinking maybe more of, people who just had the elective surgery in December or January. What sort of challenges have you heard that these people have had? And I'm thinking particularly if they were relying on going to a club, let's say, or to a gym, and all of a sudden they can't go there, they can't access the equipment. We know that depression now is hitting people across the spectrum, and people are having problems with, self-discipline and motivation. What is your perspective? What feedback have you been getting from patients?
Well, certainly, there was an incredible interruption, and as Cheryl noted, and you just noted, it's the whole self-motivation and depression, and the support that you need, the emotional support, the social support that you need immediately after being discharged. You're in significant pain. You're looking for guidance from the health professionals. Typically, people would go into a private clinic or an outpatient program, depending on what's available in their province or their town, looking for that guidance, the camaraderie of other patients who've gone through it at a similar time and how they're doing, and all that ended suddenly. And physio clinics and programs across the country scrambled to all of a sudden adopt virtual rehab. But for a few weeks there, depending on how well different clinics got up and running with that, I imagine there were several patients who were left at home with a booklet or guidance on home exercises that they were given in the hospital, left wondering, am I doing okay? Am I falling behind because of this? Who do I turn to? And we had a lot of people express real concerns and anxiety around that. And then because I had this delay in getting access to care, did it slow down my recovery? Have I not recovered as much as I could have if I'd got timely, quick physiotherapy? Should it happen, touch wood, that we don't have to slow down and cut back on surgeries and close down again, I think all programs, whether they're publicly or privately funded, are a much better place to offer quite effective, actually, virtual rehab, or what we're calling blended care with very minimal in-person care and a lot of virtual monitoring to keep people on track faster and make sure they don't fall through the cracks. But yeah, we heard a lot of concerns, and I had concerns too, and Cheryl and I have talked about that.
Yeah.
What was available to people during that, several weeks of complete shutdown there.
Yeah, I think that's one of the reasons, Dr. Westby, why on Arthritis at Home, we had Dr. Jasmine Ma come on and do a series of in-home exercise programs that could be tailored to meet the needs of people, even those that had just undergone recent total joint replacement. Certainly of a hip or knee, she offered all kinds of modifications. We also had Dr. Catherine Bachman on, who talked about, positioning and the ergonomics of doing things at home. And there's a number of programs, I think episodes rather, on Arthritis at Home that people might find helpful. I just want to say, Kelly, something that Dr. Westby said about the camaraderie of those in-person. I went to a group setting, and there were about 5 or 6 of us, and it was 2 times a week, 3 times a week. And I must say, even though we were at different, we all had our operation relatively within close proximity of one another. But seeing each other go through it, helping each other, having the odd, funny conversation, or making jokes about our scars, or, or our experience in hospital. We can't underestimate that. I think that was really important to me. And I consider myself a bit of a loner as an exercise, from the exercise perspective. And I was surprised at how much that helped me, how much that made me connected to a group of people, because we were walking a mile in each other's shoes. It made a big difference for me, and just made me feel not alone in the process. So I think that's something that maybe people have as Dr. Westby said, have kind of missed out on. And how does the system capture that if in fact we are doing still some of these things virtually, and less so in clinic? How do we still have that sense of connection in terms of our journey post joint replacement?
Some of that connection is possible through something as simple as Zoom and having group meetings. And while you might not be exercising together in the same group, you can still share your story and your challenges and your connections. And here at the Mary Pack Center, we're going to be starting some group exercises. And you're right, there have been some fantastic at-home or virtual exercise programs led by and shared with your Arthritis at Home sessions, as well as other organizations have put together some really great programs for people to do and to connect as a group. And we're looking at that for one group of our clients with ankylosing spondylitis starting in a couple weeks. So at least they can be together, sharing some of their experiences and challenges of the exercises. And I would encourage clinics or programs who are offering virtual rehab for hip or knee replacement. They could do the same thing with having like 3 of us across the screen who are about at the same stage of recovery, doing similar exercises and doing it together virtually in real time. And I think that, that's at least lending itself towards that social support that's so valuable.
Yeah, I agree. And I think one of the key benefits of that is you don't have to get in your car or get someone to drive you and find parking. I have to tell you, when you have a new joint, a new knee, or a new hip, navigating from the car, into the car, out of the car, into the clinic, back into the car, all of that is actually really stressful. And so if you can find a way, as you've said, Dr. Westby, to do that at home without parking. I know that sounds so trivial, but it's a big deal.
It's not
that could be another advocacy mission for you, Cheryl, couldn't it? Like you should have a sticker if you just
rehab with no parking. Rehab with no parking restrictions. That'll be enough. Yeah.
We're going to wrap up, but I would like to just Cheryl, for you to have the final word. And with 12 months hindsight, would you have done anything differently? No. I feel I kind of executed my plan to the best of my ability, my emotional ability, my intellectual or knowledge ability, my physical ability. I think I worked as hard as I could to attain the goals that I had set for myself. And I would say, if I could offer any pearls, it would be go into it with an uber positive mind. Go into it and we know that has an outcome, that plays a role in good outcomes. So being positive, being well prepared, so as physically fit for your operation. I worked as hard, by the way, before my operation as after my operation to get ready so that my musculature would be as ready to accept a new joint and then do rehab post-surgery as possible. So Cheryl, I guess the question is, would you do it again?
Absolutely, I would do it again. And I would do it again because I think I did the best that I could to get ready for surgery, to go through surgery, and to live a life and work my plan after surgery. I would say if I knew post hoc that I couldn't do those things, then I might hesitate. But I think absolutely it is incredible what I call it my new bionic knee, can do for me. And I don't have any pain. I don't have a leg that's shaped like the letter C anymore. I can actually, one of the best things about my knee replacement, this is going to sound a bit bizarre, but those of you who've had them out there will maybe smile and nod your head in agreement, is having a proper foot plant. Like, I can't believe what it feels like to walk on the full bottom of my foot, because for years I've been walking basically on the outside of my foot based on the structure of my leg, my kind of curvy knee. So yeah, I would do it again. And I hope I don't have to do it again, but my left knee, touch wood, is okay for now. But yeah, I would. And
All you need there is you just need a K on that knee, and then you'd have C.
Yeah, I'd have my initials, right.
Well, thank you for sharing your personal experience, Cheryl,
Thank you.
and your expert perspective, Dr. Westby. Thank you both. This completes part 1 of our special episode. We invite our viewers to join us next week for part 2. Thanks.